Good evening, everybody. It is a very honor to myself to introduce the three eminent speaker and the eminent moderator. I will introduce Dr. Khalil Allah Shibli. He is going to be the chair of this session tonight. Dr. Khalil Shibli is graduated from College of the Anesthesia in UK, and he got a degree, master degree from Maastricht, and he finished his training according to the UK standard. Currently, he is a senior consultant anesthesiologist and pain medicine and ICU and the perioperative medicine Hamad Medical Corporation in Doha, Qatar. Is not only that, he is associate section head of the anesthesiology department in Wakra Hospital. He is the site director of International Anesthesia Residency Training Program in Al Wakra Hospital. He's a member of the co-faculty and the Clinical Competency Committee in Anesthesiology Residency Program in Hamad Medical Corporation in Qatar. He's a member of Research and Audit Committee in Hamad Medical Corporation and Anesthesiology in Qatar. Dr. Khalil Shibli, we have an honor to have him tonight, and I will leave the session for his chairmanship. And just remember, all the action tonight is absolutely in English language. If you wanted to have any comment or any question, directed to Khalil Shibli, Dr. Khalil Shibli, and he will take the question and to the each speaker after each session. All yours, Dr. Khalil. Thank you very much.
Thank you. Thank you very much, Dr. Saad. All the speakers and the participants, hopefully you can hear me. And first of all, I'd like to thank Dr. Saad, yourself, and Mega Medical Association for inviting us as a group from Qatar and present some of the knowledge or share some of the knowledge. So some housekeeping points for the audience and for the participants, please, that kindly keep your mics muted during the presentations, and they can write, they can do chat, they can write question and answer sessions, and I will present one by one our speakers, eminent speakers, experts from Qatar. In fact, in the region, really, if I may say so. So we have three speakers in line. I will just say the names first, and then later on introduce before their presentations finally, inshallah, with the full names and everything. Dr. Nabil Shallik will be the first speaker, then Professor Yasir Rida, and then Dr. Nobani, our pain fellow. So that is one thing. And then without further ado, if I may introduce our colleague and our eminent academician scholar, Dr. Nabil Shallik. I take the opportunity of let the wider audience around the world know that Dr. Nabil Shallik is an assistant professor. There are so many categories I can divide his role: academic, clinical, research, and other scholarly activities. He's an assistant professor of clinical anesthesiology at Weill Cornell Medical College in Qatar. He is also an associate professor of clinical anesthesiology at Qatar University and assistant professor of anesthesiology and intensive care at Tanta Faculty of Medicine in Egypt. And he is the associate section head of anesthesia services at Promella Hospital in an ambulatory care center in Hamad Medical Corporation. He's obviously one post which all of us have is a senior consultant in anesthesia. He's published more than 45 research articles in the peer-reviewed journals, and he's a reviewer and a member of editorial boards of several journals, a member of MRC team at Hamad, author of numerous books and book chapters, leading research in airway management in Middle East. And this is his actually niche, I must say, the airway. He has pioneered, and he's the director of two major courses, basic and advanced airway courses in Qatar. In fact, in the Middle East, those are one of the two most organized courses I have myself ever come across with the from training point of view. He does simulation training, for Hamad, and he received several awards of excellence in medical education in Qatar. In the Best Teaching Award from the International Sleep Surgery Society. He's a Corporate Anesthesia Department CPD officer. Now he's looking after all the CPD in this difficult time when, due to COVID, we do not have face-to-face activities now. Active contributor to the International Anesthesia Societies related to airway management, European Airway Management Society, Research Board Committee, and the Society of Head and Neck Anesthesia. And he's a founder of Difficult Airway Management Training and Innovation Society. And he received innovation funding from the academic healthcare system in Qatar for developing 3 novel projects. So he is into invention as well for the airway devices. And one of the 3 is novel ultrasound visible double cuff device for the endotracheal tube, new video scope called Shallik scope, and ventilation with view mask. He has a lot of other credits to his CV. If I may ask Dr. Shallik, Nabil Shallik, to present his talk now on the tubeless anesthesia for minor upper airway surgery using Strive High technique. Dr. Nabil, thank you very much for joining us. And I hope I may have done a little bit of justice with your a long journey of your academics and your clinical work. Welcome, Dr. Nabil.
First of all, Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank you, Dr. Saad, to invite me to your series, online series. Dr. Khalil, I would like to thank you for this is very kind introduction. Dear ladies and gentlemen, I would like to thank you for attending this lecture. Before starting my lecture, already I created or just founder of Difficult Airway Society. This is a society for the Middle East and the Gulf area, and I hope will be partner of the international societies like DES, like EMS, like China, will be the Middle East presenter of them. You are seeing my screen, Dr. Khalil? Okay. My topic today is tubeless anesthesia for minor upper airway surgery using Strive High technique. This is a lecture. I did it after 1 week from Dr. Zaghloul lecture. He did lecture about anesthesia in 1922. Now we are in around 1920, so there is some difference in the manipulation, some drugs, some management of the patient. So I just scratch this new technique for my colleagues. First of all, I don't have any conflict of interest to declare related to this lecture. But I have to declare Armstrong Company from Ireland. She gave me one anesthesia, one Thrive machine, FD140, and 30 circuits free of charge to start my Strive High technique in Qatar. Now we have more than 20 machines belonging to our. Second thing, I cited the contents and conclusion of the following presentation are slowly to this speaker. My journey with this technique or high flow nasal oxygen started in June 2016. We did till now more than 100 patients for microlaryngoscopy procedure or minor upper airway surgery using this technique. I started first child in May 2017. I did more than 20 kids, but unfortunately, because this is service transferred to new hospital, Cedar Hospital, so I stopped to do these procedures for pediatric age group. The Strive technique, which is different from the high flow nasal oxygen technique, I started in November 2017, since 3 years till now. Now I did more than 150 cases till now. Now I'm conducting research comparing this is Apneic technique with spontaneous breathing techniques as a controlled, randomized control study.
Dr. Nabil, these are the outlines of your lecture today?
Yes, this is outlines of my lecture. My lecture will divide into 2 major parts. First part, I will speak around Thrive or high flow nasal oxygen. Second part, I will speak about Strive High technique itself. For the Strive, I will start with definition, some abbreviations. What is the basic of Thrive? What is the physiology? But I will not go in more details because limitation of time. Sure. I will also just touch the benefits for this one. For the Thrive technique, I will describe this completely with indication, limitation, monitoring, and some troubleshooting and how to treat it, and some interested video done under this technique.
Thank you. That's a very good article.
Yeah, the abbreviation today, I may use one of these today, or you can read in my slides, or even you can do internet search. So one of these abbreviation is the same meaning. The first one is the TRIVE, which means transnasal humidified rapid insufflatory ventilator exchange. Point with preoperative oxygenation insufflatory nasal therapy. High flow nasal oxygen therapy, which FNOT, double HFNC, humidified high flow nasal cannula. The last abbreviation, which triple HFNC. Any one of abbreviation I can use, you can read on my slides, even if doing the research on the internet will same meaning. But the STRIVE technique, it is not abbreviation of the, like above. It is technique using spontaneous breathing of the patient, basically spontaneous breathing himself, using intravenous drugs, with application of one of the above, maybe TRIVE or high flow nasal oxygen of these patients. Okay, what is the basic of this is high flow nasal oxygen? The high flow nasal oxygen already. Let me start with that one. Okay, here if you see this is a machine flow generator, maybe electronic flow generators, or maybe mechanical, or maybe pressure generated from the wall, connected to the machine here for humidification of the flow of the oxygen coming here, make it humidified, make it hot, connecting it to the patient through this tubing system and the nasal canal. I will show this is exactly, if I hope everyone can see it. This is already a simple machine. It is used, this is the wall with the pressure to can connect it to the patient from this here to heating chamber. I already got some heating chamber here and the humidification chamber was connected to the patient. This is the principle or of this machine. Okay, if this is the machine, another one is already this is electronic one, not manual or not pressure generated, connected to here the humidifier and the heater. This is chamber humidification and heating, connected to the patient, very simple, to the nasal cannula on the neck of the patient. This is the high flow nasal oxygen machine. Okay, this new technique, no, it is not new technique. If you see, this is article already is published in Lancet in 1968 about high flow nasal oxygen. But what is the difference between this is old one and the new one? The new one already can give you flow up to 80 liter. If you see the old one, old technique here, this is the normal flow meter. You can find this normal flow meter in any recovery room or ICU or even emergency, about 50 liter. Okay, but this is a new machine here, is can give you to up to 80 liter, but my machine here give to 120 liter per minute. So you can give the patient at one time 120 liter of oxygen per minute. Very huge one. The second one is here, the cannula itself. The nasal cannula here is soft if you compare to the other one is rigid, and a wide caliber, so not irritating the patient during insufflation. What happened for the patient during high flow of oxygen? There is continuous flow of oxygen wash out of the upper airway, so all upper airway become washed out with high concentration of oxygen. At the same time, they make a reservoir in upper airway, in the nasopharyngeal area, hypopharyngeal area, and the oropharyngeal area is full of concentrated air. Some of oxygen come outside, wash out from the mouth, to at the end result avoid the rebreathing of CO2 and therefore decreasing anatomical dead space for the patient. What happened during pre-oxygenation? The pre-oxygenation means denitrogenation of the tongue, of the lung. Just get rid of nitrogen from the lung and create alveolar reservoir. The size of this reservoir increased by reducing lung atelectasis in head-up position and raising the mean airway pressure. The size of this reservoir is fixed at the end of the pre-oxygenation. Just start apnea time, all this is the start to replenish. If you see this is alveoli, the blue sky color is the nitrogen inside the alveoli, the red color is oxygen. So at the end of pre-oxygenation, we'd like to change all this is blue sky color to red color, like charging the battery with electricity. Now charging the lung with oxygen, so it can help you in the proper time. Okay, if you see this is article which published by Sunil, he give very nice outcome after pre-oxygenation and safe apnea time. If you apply face mask for the patient for 3-5 minutes, already you started to fill the lung with oxygen or charge with oxygen, give you apnea time without desaturation up to 8 minutes. If you simply apply simple nasal cannula of this one, only increase by 1 to 2 minutes. But in the case of the Thrive or in case of the high flow nasal oxygen, you can get apnea time up to 30 minutes. What does this mean? It means if I'm working in the patient with difficult airway in one hospital and have some problem with difficult airway, if apply the Thrive, can give apnea time can be extended up to 20 minutes. So one can come from other hospital, even other place to help me in this situation. This is, if you see, this is the graph already published by Sunil also. If you found here, this is oxygenation patient started to desaturate after 10 minutes if adult fit patient. If the patient is ASAS 3 and 70 kilo, this is apnea time reduced to 6 minutes. If the child 10 kilo become 4.5 minutes. If the obese patient with 127 kilo, the apnea time becomes 4. So it depends on the physiology, on the lung condition, because of the obesity, systole compliance, all this affect the pre-oxygenation. If there is another option for the Thrive, yes. What is called is apneic oxygenation. Come to the physiological part, is a ventilatory mass flow, is a physiological phenomenon. What this means if the provide is that you have patent airway between the lungs and the exterior, nothing in between. The difference between O2 removal from the lung to the blood and CO2 excretion can create negative airway pressure. In another meaning, if you go to this is diagram, this is normal breathing patient, no pressure change of the lung. Why? Because O2 absorption from the lung to the capillary and CO2 production is equal, so no pressure change here. If you go to the level of the capillary, O2 here absorption by capillary and the CO2 production is the same. But here the story is different when the patient with apnea. CO2 started here, stored at the tissue as bicarbonate. So no CO2 more go to the blood, only O2 consumption will happen here. If you come, this is capillary one, the O2 absorbed here, so create negative pressure can reach up to 20 centimeter water. This is what is known as ventilatory flow. Okay, this is a very nice article already published in Anesthesia 2016 by Bialy. He is already tell us what the final outcome if you applied high flow nasal oxygen for your patient. Increase FiO2, increase clearance of CO2, positive airway pressure, wash out of the anatomical disease space, improve pulmonary mechanics, and decrease upper airway resistance. This is very nice article which already published in Journal of Intensive Care 2015. If you have patient with respiratory failure and applied for him Thrive, after some times here the respiratory rate started to decrease, increase oxygenation, dyspnea started to decrease dyspnea, supraventricular retraction decreased, and thoracoabdominal movement started to improve. This is the final outcome is what is known as Thrive triangle or HFNO triangle. What does this mean triangle? You have to put in your mind, it make apneic oxygenation, apneic ventilation, but somewhat not perfect because CO2 accumulation started to happen because not clear. No time we feeling any effect of oxygenation, but the problem usually raised from apneic ventilation. The last one is prevent atelectasis.
So, Dr. Nabil, thank you very much for taking us through the physiology and a little bit about the equipment. Now, what are the indications of this system, high flow nasal oxygenation? You've described very nicely. So let's move on to discuss the indications, please.
Yeah, thank you, Dr. Khalil, for your question. The indication will be have two major indications. One indication in the OR and the ICU settings, and second one in emergency situation, maybe in emergency department, maybe in the ward, maybe the ambulance. This is emergency case. Can help us in pre-oxygenation in all patients, especially difficult airway patient. Endotracheal intubation in ICU setting, in bariatric, pediatric, or obstetric patient. Can help us during a week intubation for upper airway surgery. This is my concern today. Can help us post extubation in difficult extubation cases. can help also in post-extubation and long-term ventilation patient, and difficult airway guidelines algorithm. I would like to announce for you, Dr. Khalil. Already I sent this article for British Journal of Anesthesia 2019. The title of this article is the time for high flow nasal oxygen to be included in difficult airway algorithm. And second, the article I published in Trends in Anesthesia and Intensive Care in same year 2018. The title was High Flow Nasal Oxygen is the time to update ASA difficult algorithm. Now there is new revision of ASA guidelines going on now as airway experts from the world send from letter how to improve how this, and already I hope that they can include thrive or high flow nasal oxygen in the next version of ASA guidelines. Other indication in the emergency things can help us in airways instrumentation and rapid sequence induction and intubation, can help us in hypoxemic hypercapnic respiratory failure, can help the patient hypoxemia induced by heart failure, ARDS, OSA patient, minor procedure under sedation in emergency department can be done under TRIVE. Post-extubation respiratory compromise, claustrophobia, especially you would like to apply non-invasive mask and the patient afraid, you can apply instead of TRIVE. Some cases of stridor of end of life. This is not only the definitive treatment, but it is you just buy the time to the next definitive treatment to come. What are the benefits of the STRIVE?
Yeah, what are the benefits of, I was coming to the point. What are the benefits of the STRIVE High?
Yeah, before coming to the benefit, I will again re-explain what is the terminology of STRIVE, because many people joined later and did not attend the first two slides about the definitions. This means I am keeping the patient spontaneous breathing using intravenous induction drugs or intravenous sedative drugs with application of the TRIVE. There is some benefit related to the surgery itself and some benefit related to the patient. Surgery limit OR gas pollution because you are using only TIVA, no inhalational anesthetics. It facilitates oxygenation in the patient with severe laryngotracheal stenosis, facilitate oxygenation in tracheostomy under sedation, give more time for airway procedures, and give wide space for the surgeon. If anyone working in the ENT when asking to do microlaryngoscopy, usually choose microlaryngeal tube. This is microlaryngeal tube. Usually we choose 6, 5.5. The 6 is only the inner diameter, but still the outer diameter is 8.8 millimeter. What does this mean? If you have lesion inside this one, still 8.8 millimeter would interfere with the surgery. So when the surgeon is working in the environment without tube, he can play football inside the vocal cord of the patient or glottic area without interference. The other benefit related to the patient, no stress of ventricular intubation, no post-intubation complication. Again, it facilitates dynamic airway assessment, no risk of the barotrauma compared to the jet ventilation. Can be useful in some procedure sedation like endoscopy, bronchoscopy, or ARCP. If you see, this is a very nice audit, which already published by both in Anesthesia Intensive Care in 2016. He audited around 285 patient, adult patient under this technique without any barotrauma comparison with jet ventilation.
Nabil, what are the limitations of this technique, what you had described, because it's a high flow technique with the intravenous administration of anesthesia?
Yes, still like any procedure, some limitations. This limitation come from this is experience. You need expert anesthetist and expert surgeon at the same time.
That is a prerequisite, obviously. That is a prerequisite, like an expert, like monitoring, an expert person, expert environment. I think that's a prerequisite. Am I right? Like,
yeah. Also, airway obstruction, especially have nasal obstruction or complete airway obstruction at any level from the tongue to the trachea. Recent airway or nasal surgery, patient with a trauma or bleeding or fracture ribs of skull. Suppose patient have like post-tonsillectomy bleeding or patient with epistaxis, it's difficult to apply TRIVE for this type of the patient. Also, upper airway infection, even COVID infection is contraindicated to use this technique also because this will make more aerolization of the virus outside. Morbid obesity, very difficult airway. Anyone can ask you this question: can we use this Thrive with laser or surgical diathermy? Before answering this question, I have to scratch my hair, because my answer may be yes or no. Yes, if you already decrease FiO2 to the 40%, and the new machines now have some blender can decrease the FiO2 up to 30, even 20. But if you couldn't decrease, it is contraindicated in presence of laser and the presence of diathermy. The second limit, the last limitation is CO2 accumulation, and this is very important and crucial for us. If you see here, this is two articles published. It tested that CO2 accumulation during apnea. It found CO2 increase by 0.27 millimeter mercury per minute in the Apneic technique. But with the Thrive technique, after 45 minutes, only the increase is 0.2 millimeter mercury per minute.
Sound, Dr. Khalil.
Sorry, I keep muted myself because I didn't want any noise from my side. So basically, now we are heading towards the end of the presentation, Dr. Nabil, if I may say so. So let's discuss the complications, if there are any, and I'm sure there must be. After the limitations, you'd like to discuss the if happens. Obviously, nobody wants complications, but there might be some complications which everybody would like to know, if from your experience, from the literature, and so on and so forth. Thank you.
Sure, Dr. Khalil. I have some complication I have to share with my people, especially people interested to practice this technique. Sometimes it's spasm during surgical manipulation, sometimes aspiration of gastric secretion or blood because it is open airway at the end, hypoxemia or hypercarbia. During my long working more than 300 patients now, no hypoxemia happen, but the problem come usually from hypercarbia. If you have detached masses or particle can easily be aspirated. Fumes can be aspirated from the laser or diathermy. Airway fire from oxygen, and some case report published here. This is the first two cases published here. The gastric rupture following nasogastric catheter oxygen delivery. He reported around 2 cases in adult here, but this is case report in the kids. Pediatric case developed critical abdominal distension caused by a combination of Thrive and the nasal airway. But when I read it in more details, found this is the two operators here, or two authors did not use the manufacturer guidelines. The manufacturer guidelines ask don't use this is a Thrive machine with nasopharyngeal airway or any catheters because will make some complication, and this is happen for this case. This is another case happened with Thrive. This is my friend Imran from London. Already he published this case, intraoral ignition of monopolar diathermy using Thrive during maxillofacial surgery. So one of the contraindication here to using 100% oxygen, you can decrease by blender to 20%.
You unmuted. So what are the anesthesia techniques for Thrive high recommended techniques?
Yeah, this is second part of my lecture today to go the Thrive. I will go back with around 5 years back. I attended WAM1 in Dublin in 2015 in November. I remember the date like today. And after this one, I went to, after finishing, this is with my friend Anil Batil from London in UCL to attend some cases with him. At this time, he already has published a very interesting article about using this technique for Apneic technique without tube in the airway. And yesterday only I found the citation more than 300. He already, Anil, he is doing very, very strange thing. He giving the patient induction agent, muscle relaxant, narcotics, and ask the surgeon working without anything. He give him around 30 minutes and there is cut off of CO2 accumulation. When I saw the first patient with Anil, this is my face at this time. What happened, Anil? What is this? What is this, Anil? Okay, I now described my technique because my technique is little difference because Anil is keeping his patient apneic, but no, myself, I am keeping the patient spontaneous respiration. Patient wash himself, clean his CO2. So the cutoff of Anil is around 20-30 minutes, but now I can go to 2 hours because still patient start ventilating himself using this technique. As a part of this technique, I am apply the Thrive. This is an apneic technique used by traditional, by Anil. He is Tiva, propofol, remifentanil, muscle relaxant. But my technique, I am using, this is propofol TCI. I'm using TCI pump. With the next slide, I will describe the regime in more details. I just use very little dose of fentanyl, maybe 0.3 to 0.5 mic per kg. Sometimes dexmedetomidine in very minimal doses can help me in analgesia and keep the patient spontaneous breathing. But the most important golden trick here, you have to spray the vocal cord with lidocaine 4% plus phenylephrine or any vasoconstrictor before starting the procedure. Really, the main analgesic for this procedure is the local anesthesia of the vocal cord and upper airway. This is very important for the people who would like to read or to practice this one. Go to this, both is published. This is article in British Journal Anesthesia 2017. He used SCV means spontaneous ventilation during stepwise target controlled anesthesia of propofol using CB minus C. CB means predicted propofol plasma concentration as indicated in the blue color. CE predicted propofol effective site concentration as indicated by this is red color. The technique, I'm adjusting the propofol TCI pump by patient parameter and using Marsh model. We started with my target first is 3 microgram per ml for the first 5 minutes. At the end of this 5 minutes, the patient started loss of concentration. For another 2.5 minutes, I increase TCI by another 1. So after around 7.5 minutes, patient can do jaw thrust for him and increase the flow of the thrive from 30 liters to 70, 80 liters. After sometimes to 10 minutes, I can spray the vocal cord with local anesthesia and the vasoconstrictor agent. Around 12 minutes, I ask the surgeon to put suspension laryngoscopy and started working with breathing patient, with normal breathing patient. This is our setup. First of all, I would like to thank my technical staff in ambulatory care center and my surgeon. He's always working with me in situation. Allah Yashfi, Dr. Muayyad. The setup, the patient go inside OR, we sleep flat with monitors connected with the high flow nasal cannula here, and put the patient in the trend in the semi-sitting position, and they started to drive him to 30 liters because it's conscious. Patient conscious can accept up to 30 liters, but with anesthesia with sedation, it can go up to 80 liters per minute. By the regime before, around 12.5 minutes, spray vocal cord and ask him to do suspension laryngoscopy here. This is video show us how really we can spray the vocal cord with this one. This is a mass inside the vocal cord. I am spraying now the vocal cord, epiglottis, base of epiglottis, and sometimes go inside trachea to using this is magic device. I hope everyone can see this is magic device. Just spraying the local anesthesia using this is magic device. The anesthesia regime in kids a little bit different, but the same. You can use Tiva with propofol or 1.5 milligram per kg per hour plus Brisedex, and sometimes add ketamine to keep your patient spontaneous. Why I didn't use TCI? Because at this time I didn't have the TCI protocol inside my pump, but now recently we have we can apply with this TCI in the pediatric age group. Again, golden trick, you have to spray the vocal cord with local anesthesia as before. And also should be repeated every half an hour if the procedure longer than this is time. This is very useful table for the people interested to use in the pediatric. This is liter per minute according to the body weight of the kids.
Dr. Nabil, we have reached a point where you have described, we have the whole process you have taken us through now. A very puzzling point for me as an anesthetist is while you're doing and getting involved with so many things with your technicians, with your colleagues, you have to monitor your patients for not only the vital signs, but very specifically for an airway matter, airway issue. So how you are ensuring all that? Because if it's a normal tube, normal anesthesia, we all know what we monitor. But with this particular technique, with your TCI regime, using dexmedetomidine infusions and all that, how would you ensure that you are monitoring a patient, and what monitors are required? What are the prerequisites?
Besides this is basic monitor I'm using for saturation, heart rate, blood pressure. In Tubeless, it is impossible to come here because no tube in the field. Okay, at this point I'm using transcutaneous CO2 for measurement of this one, plus a special ECG cable can give us respiratory rate. So if you see this by monitor here inside the operating room, the first green one is heart rate, second one is the respiratory rate. The green part here is the transcutaneous CO2, the saturation. This is BIS or PES readings. This is temperature, and this is the blood pressure of the patient. If in this patient is specifically, I using transcutaneous CO2 plus this than ordinary patient. This is some troubleshooting can happen during this one, and it is very important. If you manage this technique, you have to manage this is like troubleshooting or some mishaps during the first one is you found the patient is still reactive to the maneuver. You can increase depth of anesthesia, you can re-spray the local anesthesia again of the vocal cord, or sometimes you can give little remifentanil, very minimal doses to present this reactivity. And the reverse direction, sometimes they become hypopneic from you or apneic, decrease the depth of remifentanil. You can stop remifentanil completely or decrease the depth of propofol concentration. Can apply face mask. If failed, you can put LMA or jet ventilation, or at the end you can do tracheal intubation. The complete airway obstruction, just very simple things. You can do jaw thrust for the patient, simple adjuvant, or do tracheal intubation with normal tube or straight tube, or at the end you can do surgical airway if all this failed to manage your patient. During the during the airway surgery itself, you sometimes happen from surgeon. He's pushing the suspension laryngoscopy completely, and he's closing the glottic area completely from here. So no air or no oxygen can go inside. So ask the surgeon, please withdraw the suspension laryngoscopy little up. Subglottic and supraglottic intubation. What is the difference between subglottic and supraglottic intubation? Usually in all our cases in anesthesia, we're doing infraglottic or subglottic intubation because the tube will be in the trachea. But here supraglottic intubation, during the surgeon is putting suspension laryngoscopy, you can put the tube inside the vocal cord, inflate cuff in the pharyngeal cavity, and make some ventilation for some times till patient started normal breathing again. You can remove the tube and ask the surgeon without interrupting the surgical procedure. So this is supraglottic intubation. During now 4 years, I only used one time surgical airway for cricothyrotomy using Ventrain, and 2-3 times just to use the tri-tubes. My backup plan, usually difficult airway troll will be in my background. Usually microlaryngeal tube with small size with videoscopes is available. Jet ventilation is the second plan. Tri-tube and the Ventrain will be the third plan, and surgeon is around me at the fourth plan if something happens. What is the tri-tube? Tri-tube, this is the newly tube, or they come from Ventinova, from Holland. This tube is outer diameter is 4.4 millimeter, the very thin tubes, but the inner diameter of the tube is 2.4, so you can ventilate this patient through 0.4. Other two lumen, one this is adult cuff, second one is the inflation cuff or balloon. No machine in the market can ventilate the patient through. This is very small, like cannula 14, except the Ventrain. This is manual one, or Yvonne, and already I have one in our center. We can manage the patient using this ventilation.
You have shown us some videos. So what are those videos you're coming with the challenging cases? What do you mean by challenging cases? Is it the time-wise challenging cases, or the maneuverability of the equipment, or the oxygenation challenge within the airway? So just share with us, what do you mean by challenging cases, please?
First of all, this is ambulatory care center. This is my hospital I am working. And I would like to thank also the technical team helping me in these cases, surgical team also as well. The first video or this one to show us how can use this technique in the facilitate dynamic airway assessment. This first patient, our first case scenario is tracheoesophageal fistula patient. This is female patient, 55 years old, female, known case of seizure disorder due to viral encephalitis, intubated and ventilated, and complicated by iatrogenic tracheoesophageal fistula. Already we operated this patient 4 months back before this procedures, but now after came again with history of frequent aspiration and chest infection. Patient already posted for examination of trachea under Strive-High technique to diagnose. Why we asked like this? Because the surgeon sent the patient for radiology department. Patient at one day she did barium swallow and CT. The barium swallow comment came like this: no obvious evidence of tracheoesophageal fistula at time of examination. But same day, redemonstration of the proximal tracheoesophageal fistula found. I asked my surgeon, is Dr. Dogan. I asked him, Dogan, please bring your patient. We strive the patient for you. If you see here, this is spontaneous breathing patient, no tube in the field. As you see, some secretion started to appear here. This is now going above the carina. And if you see something started to appear here. If you put any tube in this field, it may be impossible to see where the fistula. We can go beside the fistula to diagnose this is the tracheoesophageal fistula for this is challenging patient. Here, this is one is now you can see clear tracheoesophageal fistula. In this patient, I enter the stomach from the trachea to confirm the diagnosis of tracheoesophageal fistula. This is one of the indication of this case. Second interested case, already with airway pathology. This is very nice guy. He's 46 years old male with history of voice abuse. He complained from hoarseness of voice 6 months. He has difficult airway due to limited mouth opening, really difficult airway, stiffness in the neck, limited movement, extension and lateral rotation of the neck, melanopathy grade 4 with large tongue and crowded mouth. Patient examined in the clinic with nasoendoscopy. He's found the polyp. Very simple technique with 5 minutes, you can remove the polyps and send the patient home. But here the surgeon, he spent 45 minutes to insert suspension laryngoscopy because this is difficult in airway, and he refused. At the end, he asked me, Nabil, please recover the patient. I will not do the operation. I told him, wait, please, don't recover the patient. I brought our fiber optic, this is 5.5 with side channel, and enter inside with using crocodile forceps in the channel of our fiber optic, anesthesia fiber optic, and remove the mass within 5 minutes. And the patient discharged home with the operation without rescheduling him again. This is with this one, this is another challenging cases for us. Patient difficult to do suspension laryngoscopy, and we have to do something for the patient. If you see here, patient, no tube in the field. The patient sometimes reacts, sometimes breathing for you. Okay, the mass now is removed. Re-examination, no bleeding, recover the patient. After 2 hours, the patient went home. This is another challenging case. He's 40 years old male, not known to any chronic illness. He's obese, 45 years old. Patient attended difficult airway clinic. We have already in ambulatory care center difficult airway clinic for these cases. With patient attended with difficulty in the breathing, with huge enlargement of the mass and the neck swelling, became stridor. Patient orthopedic and they need 3 pillows for sleeping. During nasoendoscopic examination in the clinic, he found the big mass is vascular in nature, occupying most of the trachea, and only 3 millimeter fibroscope passed with difficulty. This one, I did for this patient visual endoscopy and the 3D reconstruction of the airway. Found the tracheal is only 4 millimeter in the narrowest area of it. Patient posted for thyroidectomy, excision of the sternal mass, possible tracheal stenting. Okay, just share with you the video of the patient. If you see here, This is the visual endoscopy of the patient with tracheal stenosis. This is again MBR for the patient with severe stenosis. This is the extension of the lesion of the sternum, destroying the sternum. Here examination, if we found here the tracheal compression from thyroid mass compressing the trachea about only 4 millimeters can pass this area. This patient, as you see, spontaneous breathing. You can examine the airway. You can decide which technique can intubate for the patient or how can you manage this patient. I inserted the tri-tube inside. If you see here, this is fiber optic is parallel to tri-tube now. It is pushed with little pressure because it's difficult to take both. I adjusted the place infra mass or distal to the mass, the tracheal cuff of the tri-tube, and ventilated 6 hours to remove the thyroid, to remove the mass from the sternum, and the patient went to ICU after this one. Another interesting cases, I published these cases last year. It's 40 years female with tracheal stenosis after tracheostomy. Patient has history of malaria, complicated with renal failure, respiratory failure, and need ICU admission and tracheostomy. After closure of tracheostomy, started of tracheal stenosis at the level of second and third tracheal ring. Patient posted for balloon dilatation and laser cutting of the airway. We have to answer this question. This patient, tri-tube can be effective. Second one, may need tracheostomy, may need ECMO. We'll see the video. This is a video for the patient. Yeah. If the patient, this is given normal airway from outside, but from inside you found this is challenge for this case. Found here, this is trachea. See the stenotic area only pass around 4 millimeters. So tri-tube can close the field. Sometimes they need laser. This is an example to use. Can use the laser in the presence of high flow nasal oxygen. But at these times, I decrease the FiO2 to 30% and ask the surgeon to laser the patient. Okay, here is passing the balloon inside this lesion. This is very important trick here. You have to stop respiration of the patient during balloon dilatation. Otherwise, the patient may get pulmonary edema from you during this negative pressure pulmonary edema. So at this patient, at this time of balloon dilatation, I increase, I give more doses of remifentanil to stop respiration during the balloon inflation. 2 times balloon dilatation done for the patient, and the patient went home safely. This is second time of the balloon dilatation. Okay, this is another patient. I have now series of the patient of post-COVID tracheal stenosis after intubation. I have now 6 cases. I am preparing for publication. I will show now 2 of them after COVID. This is first one. If you see here, this, I would like to thank visual endoscopy and the 3D construction of the airway to show us here. This is the anterior posterior diameter is 4.2. Lateral diameter of tracheal stenosis is around 3.3 millimeter. So how can we manage this one? This now under strive high technique, patient is spontaneous breathing. I enter by fiber optic inside the trachea of the patient and see the stenotic area of the trachea. At these times, I put new technique. I kept here guide wire inside the trachea of the patient because it will help me for insertion of tri-tube over this is guide wire in the management of the airway. When the tri-tube in the place, I give mass relaxant of the patient and complete the procedures of removal of this is one under forceps cutting and balloon dilatation. Here the tri-tube in the field, the patient started to coughing. I increase the dose of the drugs to become silent again. Here the tri-tube in the field, the surgeon started here to do cutting of the fibrous tissue around the tri-tube. He did balloon dilatation 2 times and recovered the patient. The second, the COVID patient, this is a very interesting case also. See here also, this is obstruction, very tight obstruction here. Examination of the airway also done with fiber optic under strive high technique. If you multiple stenosis of the trachea, I do this the same. Keep the guide wire inside, put the tri-tube over the guide wire, ventilate the patient with Evone for the completion of the procedures. Another two videos for pediatric age group, the very challenging videos. The first one is child 9 years old, female with congenital anterior laryngeal web. This web is covering anterior two half of the vocal cords with no extension subglottic area. As a complaint, history of change of the voice and hoarseness of Sensberg, mild difficulty in the breathing. The patient is posted for cold dissection and suturing on the flap. Here, if you see here, where can we put the tracheal tube? If you endotracheal tube here, will close the field. The surgeon will not work at all, and this is very small airway for the baby. So it is now free. He's tube free now. Now surgeon started to cut the anterior laryngeal web using scissors. I think if any tube in the field here, he will not move freely or cut freely like this one. He started do suturing of the flap, and the patient recovered well. The second one is here. This is really very critical for myself. It's 7 years old patient with left vocal cord cyst. No history of dysphagia, but difficulty in the breathing. Patient done under drive the duration was 30 minutes. If you see here, this is sorry, it is dark little bit because this is recorded from microscope of surgeon. We find here where can you put the tubes, and even the bag mask ventilation of this patient can make suffocation because this is ball and the valve effect can affect here of the patient. No area you can pass in the tracheal tube, but already the surgeon started to work in the free area for without tube to managing this type of the. Again, for same day, I have another patient with very big mass in the field. This is sound is high. This is a thrive sound. Usually, this noise come from the sound of this one. The very big mass. Where can you pass your tubes? And even bag mask ventilation can affect the life of the patient. Close the glottic area problem. This is the last patient, already 4 years old, the baby, known case of recurrent papillomatosis. Patient complaining of bronchial asthma. He has voice change, difficulty in breathing, even in 45 degrees. We did this patient 4 times for debrider, micro debrider, and debulking of the airway, but this is the most difficult one we faced. I will just ask this question, and you can answer during the video itself. How can you intubate this baby? Tritube not available in the pediatric. We need ECMO, we need tracheostomy, and this is a child age group. The mass is very fragile, can easily touch it and can aspirate it quickly. So see the video, and this is my impression when I saw the video of the patient preoperative for the surgeon. Okay, come now for the recurrent laryngeal papillomatosis. This is started papillomatosis from supraglottic area here, closing all glottic cavity to subglottic area. Surgeon here started to working on the tubeless area or tube-free area to debrider, remove all the tissue. And sometimes there is conflict between the surgeon, don't use the debrider with the fluid, because as a habit using with fluid, sometimes putting the batty closing the airway for me. But at the end, we manage the patient safely, clear the airway and the patient safe. This is the last video, Dr. Khalil.
Yeah. You have a this was the last video you said, yeah? So
Yeah,
we are going to go heading towards the summary and then the question and answers. Yeah. So how would you summarize now, please? Then maybe your summary might have the answers to some questions.
Yes. Strive high is an open airway technique that might have advantage over compared to traditional technique during our airway surgery. There is growing attention and interest for potential use of the Thrive and strive high technique in airway management, but no, not a substitute for good airway management tools. Still, we have many limitations and complications. To be standard technique, it needs more practice, need more expertise, more guidelines, and more research. Thank you for attention, and I think this is a very interesting topic. Will open your appetite for questions. I am happy for answering any question.
Yeah, thank you very much. Thank you. Can you hear me all? Yes, Dr. Nabil, you can hear me?
Yeah, I'm
Yes,
hearing you.
yes, yes, yes. So that means everybody else is hearing. Thank you very much.
Yeah.
Very quickly, I just want to take the liberty to ask first question. What is the typical duration of the surgical procedure or any procedure you're undertaking with this technique? I'm not talking about the preparation. I know it is very intense preparation, but what is the typical actual procedural time?
Yeah.
Can you just tell us?
When I started with Apneic technique, my cut time is 30 minutes or CO2 accumulation to the critical level. At this time, I stopped the technique and put tube or other alternative. But when I started using Strive technique, still patient, spontaneous breathing, the last video of the baby took around 72 minutes of the procedure. So patient is still breathing, he's clear his airway by himself, he's washed himself. This is the time for me.
So now we have few questions, and I think there are some answers already given, but these are one-liners, and you can answer in one line actually. So one of the question from Mustafa Risk is, can we use Thrive technique in tracheal stenosis or only tri-tube?
Yes, thank you, Dr. Mustafa, for this question. If you see the video, I have two videos. One video I did only with the Thrive technique with laser, because at this time the tri-tube not available at my site. But now this is in the recent, because I have tri-tube and the Yvonne ventilator, so I usually take the more safe of the patient to put tri-tube and ventilate the patient.
Thank you. Dr. Najat asked a very interesting technique. But how can it be that the difficult airway is one of the limitations and indications both? So this is an interesting question, but I'm sure you have an interesting answer for that. Yeah.
No, this is okay. And sometimes difficult intubation, the technique is help you to diagnose, like all cases of tracheal stenosis. Already they use the technique to do good plan for the future. What is the good plan for you? You can do tracheostomy, you can do tri-tubes, awake the patient. It just help me. This is one step for you to help you in the future. But don't do completely the procedure with difficult airway at any time in the between. Patient can feel for me, you couldn't intubate for the patient, you couldn't management. So this is the first step to do what is the next plan after study of the patient airway.
Thank you very much. Dr. Taha asked one question. Does this HFNO technique during apnea under anesthesia has a bad impact on gastric inflation and more risk of gastric regurgitation or vomiting?
No. We tried. There is one study done by Basim, my friend, and he is the vice chair of China. He's just published last month about when he's measured that the airway pressure. He found the airway pressure when closing the mouth using the Thrive only 7 to 10 centimeter water, and this is higher than upper esophageal sphincter. So the inflation of the stomach become less. And again, if you saw the 2 case report already published for inflation of the stomach or perforation, because he put the nasopharyngeal airway or tube for inflation, so he's bust already the sphincter and the make inflation of the stomach.
Okay, I think I'm just going to skip 1 or 2 questions which has been answered by you. So can we use it? Dr. Amira asked, will we use it for dental procedures?
Again, if you
I assume the dental procedure with the airway problem. I assume, or is it just I'm not sure whether she meant.
No, it can use, but the problem, Dr. Amir, what happened during dental procedure is there's some water in the field, all of this one, and this is the Thrive will spread all of the water and make aspiration of the patient of the water. But if you have clean field, okay, you can apply for this one for sedation during the dental procedure. But if there is blood, if there is some secretion, some fluid for irrigation, sure, will soil the lung by this technique.
Thank you. My apologies for the others, but I think the questions have been answered in your presentation when the questions were falling in. Dr. Muhammad Suleiman asked, do you have a plan to train such highly specialized technique at international level?
Yeah, Dr. Muhammad, already, thank you, Dr. Muhammad. I have already many visitors from HMC and from outside MC to do this technique with me. And I know you, if you are happy to come at any time, you are most welcome.
And to all the audience and the participants, I always say with this such a wonderful presentation, Dr. Nabil, I must say, you have started from the beginning till the end with the practical demonstration, lots of cases. This looks really nice, but my only advice is do not try at home. That's any magic trick I see, I always say, do not try it at home. So if you like to be trained, you can contact Dr. Nabil or our group, and then we can help you get here or do more sessions for this one. So this was really, really an amazing lecture. Dr. Nabil, last word, please.
Yeah, last word, not related to the lecture. Let's know this is the QR code which appear in front of you. Just scan this one. If you scan, we'll go to the DAM Society website. You can see what is the teaching material inside, what announcement of the courses in the future, inshallah. Thank you for attending. Thank you, Dr. Khalil.
Thank you, Dr. Nabil. Thank you very much, and stay with us, please, for the next talk.